Chapter 20, Documenting and Reporting. On page 518, under Documenting Care, documentation is a written electronic document of all pertinent interactions with the patient, which includes assessing, diagnosing, planning, implementing, and evaluating. So that's our first two bullets on the slide. The next sentence, special attention to it. You can expect to hear repeatedly, if it was not charted, it was not done, from your clinical instructor. So this reinforces the need for accurate recording of patient information, accurate information being documented by not only the nurse, but by other providers as well as the physician. Also, special attention to the first sentence in the second paragraph. The patient's record is a compilation of a patient's health information, or PHI. So I need you to know that as well. So on the third bullet on our side here, documentation facilitates evidence-based patient care, serves as a financial and a legal record, supports clinical research, supports decision analysis. So characteristics of effective documentation, or guidelines for effective documentation, begins on 518. So documentation should be consistent with professional and agency standards, complete, accurate, concise, factual, organized, and timely, legally prudent, and confidential. So we are not putting our opinions in here. We are putting strictly facts, and it should align with our guidelines for our profession. Elements of documentation or documentation guidelines begin on page 521, box 20-1. So each of these bullets are explained in this box in detail. So you want to make sure that you are documenting the proper content, make sure that it is professional, right? That it is the patient's findings. You want to make sure that it is factual. Timing. To document in a timely manner, you should document when the event occurs, at the time that the treatment was done, or at the time that you were made aware of the event. However, it is important to make sure that the timing is accurate according to the procedure, and it is within the guidelines according to your profession and your facility's policy. Formatting. So you want to make sure that you're using the proper format. You're recording the information in the proper document, proper screen, okay, according to your profession as well as your facility's policy. And the intervention should be in chronological order. Never skip lines or leave spaces when making your documentation. Accountability. So you must sign or initial your documentation so that they can be traced back to who actually provided the care. So if in fact you make an error or a mistake, you do not want to use any correction fluid. That is illegal. You want to draw one single line through it. Okay, you should not scribble it out. One single line through it and write mistaken entry. Okay, your book does say you can write error in charting. However, it is my understanding that error in charting is no longer the best option, because in a court of law, you are admitting to an error. So the best option is to write mistaken entry and then write what the correction is right above it or beside it. Confidentiality. So you must recognize that this is a legal document and this information should be confidential. You cannot be talking on the phone in a public area about this. You cannot be talking openly in the elevator about what's happening with your patient. This is confidential information that you wrote in the chart. And if, in fact, there is no reason for the individual to know that information, it's no reason for you to share it. And if I can go back to timing, most facilities are utilizing military time and use 2400 time cycle instead of a 12-hour time cycle. So you want to be aware of how to interpret that as well. So I know you're all familiar with military time at this point. However, I did want to point out this center is showing us our AM on to 12 p.m. and then the outer is showing us our PM military time up to 12 a.m. So what is confidentiality begins on page 520. So all information about the patient written on paper, spoken aloud, saved on a computer is considered confidential. On page 520, they have bullets and it gives you examples of breach and confidentiality. So that very first one, it says discussing patient information in a public area. So the elevator is considered a public area. If you're in the cafeteria and you call someone on the floor with your personal phone, that is still a breach, right? You should not be utilizing any equipment that's not issued by your facility. So read through these bullets and just understand them. So the confidential information is considered the name, the phone number, the fax number, the social security number, the reason the patient is sick, treatment plan for the patient, and any information from their past medical history is all considered confidential. A nurse does not log off of the computer after documenting. The patient's care has breached patient's confidentiality, true or false? Failure to log off the computer after documenting is a breach in confidentiality. So the answer is true. You must log off immediately after documenting if you step away from that computer. All right, so potential breaches in patient confidentiality. So this is on page 522, table 20-1. It states tips for preventing breaches in patient confidentiality. So it has the types listed and then how to prevent it. So I suggest you read through this. So displaying information on a public screen, sending confidential emails in a public network, sharing printers on units, discarding copies of patient information in trash can, holding conversations that can be heard, faxing confidential information to unauthorized persons, and sending confidential messages over the pagers, overheard on pagers. On page 522, at the very bottom, we have several bullets which align with this slide. So according to HIPAA, patient have the right to see a copy of their health records, update their health records, get a list of disclosures that the healthcare institution has made, request restrictions on certain use or disclosures, choose how to receive information. So we have a question. Patient has the right to obtain, review, and revise the patient information in his or her health record, true or false? And the answer is false. A patient has the right to obtain, record, and update their record, but they are not permitted to revise the patient information on his or her health record. On page 528 at the very bottom and extending into page 529, it speaks about policies for receiving verbal orders. So it must be given by a physician, nurse practitioner, or a registered nurse, or a registered pharmacist. So verbal orders are recorded in the patient's record. The person receiving the verbal order should read it back to the person giving the verbal order to verify accuracy. The date and time in which the order was issued must be documented. Record the verbal order, the name of the physician or nurse practitioner issuing the verbal order, followed by the nurse's name and initials. And should be limited to urgent situations only. Policy for physician and nurse practitioner to review of verbal orders. So review orders for accuracy. They also must sign their name, title, and pager number note the time the order was signed. Okay, we have a question. One of the purposes of creating a patient record is to evaluate the quality of care patients have received and their competence of the nurse providing the care. True or false? And the answer is true. One of the purposes of creating a patient record is to evaluate the quality of care the patient has received and the competency of the nurse providing that care. Methods of documentation begin on page 530. So you can document in a computer or electronic health record. Also, source-oriented records such as progress notes or narrative notes. Problem-oriented medical records such as SOAP notes, which probably are not used very often nowadays. Then we have something called pie charting, which is the problem, intervention, and evaluation of the intervention. Focus charting, so you just focus on one particular area, and charting by exception. So you're only charting any abnormal findings. Everything that appears normal does not need to be charted. It is understood. So this is a sample of a focused patient care node. This is the DAR format, or data, action, and response. So I do want to also bring your special attention to page 532. Very top on the right side, patient can access their own records through a secure portal and see, for example, the trend of their lab results over the last year, their immunization history, or due dates for upcoming screenings. So this patient portal, many of us are familiar with it. It's called MyChart, or different systems may have a different version, but I know Jefferson uses MyChart. A lot of healthcare facilities use MyChart. Which method of documentation is unique in that it does not develop a separate care plan, but instead incorporates the care plan into the evaluation progress notes? So A, source-oriented records. B, problem-oriented records. C, PI or problem intervention evaluation. D, focus charting. And the answer is C, PI, problem intervention evaluation. Pie charting incorporates the care plan into progress notes in which the problems are identified by number. In source-oriented documentation, each of the healthcare groups keep data in its own separate form. In problem-oriented records, they are organized around the patient's problem rather than around the source of information. And focus charting brings the focus of care back to the patient and the patient's concerns. Formats for nursing documentation begins on page 535, extends into page 538. So the different formats that are listed in these pages have a paragraph explaining each of them. I suggest you read through it. So those formats include initial nursing assessment, the care plan or patient care summary, critical collaborative pathways, progress notes, flow sheets and graphic records, medication administration records, acuity record, discharge and transfer summary, home health care documentation, and long-term care documentation. So guidelines for Medicare with home health care. So the patient is homebound but still requires skilled nursing care. They have good potential for rehab or they're dying. They are not stable, but they are making progress to obtain the outcomes listed in their care. So in long-term care facilities, they use the Resident Assessment Instrument, or RAI, also known as the Resident Assessment Tool. And this tool is called the MDS, or Minimum Data Set. This MDS is a document that compiles a summarization of the patient's chart. It triggers certain areas of the patient's care plan that must be addressed. In addition to that, it provides guidelines for care for that patient, and it is utilized for reimbursement. So that utilization guidelines, it is submitted to the state, which determines the facility's reimbursement for the care they are providing. So this is a very important document. So the benefits of RAI: resident response to individualized care, staff communication becomes more effective, resident and family involvement increases, documentation becomes clearer. Page 538 to 542 describes each of these bullets in detail. So these are different types of reports you may give when reporting off or requesting some action from a colleague. So change of shift handoff report. We have our ISBAR. We have the telephone or telemedicine report, transfer and discharge report, report to family members or significant others, incident variance reports. On page 539 and to 540, box 20-6, it explains the ISBAR in detail and also gives you some examples of an ISBAR. So read this in detail. However, the acronym stands for Introduction or Identify or Identity, Situation, Background Assessment, Recommendation, Readback of Order or Response. Change of shift handoff report begins on page 540 and continues into page 542. So this report is giving you the basic information needed to care for your patient. So patient's room number, diagnosis, attending that's caring for them, their health status, current orders, any abnormal findings during your shift, any unfulfilled orders for such as labs that may need to be drawn or awaiting a result from a lab, any questions, concerns from the patient or family, and any plans for discharge or transfer. Telephone or telemedicine report begins on page 542. So identify yourself and the patient and state the relationship to the patient. You want to be very concise and accurate when speaking about any changes in the patient's condition or any concerns that you have. Report the patient's vital signs or any clinical manifestations or anything that's pertinent, right? And you want to make sure that you are knowledgeable about the patient care so that you can respond to the physician's inquiries properly. And concise, clear, concise record or recording of the time and date that this communication occurred is essential. Conferring about care begins on page 543. To confer is to consult with someone, to exchange ideas, and to seek information, advice, or instructions. So this can include consultations, referrals, nursing and interdisciplinary team, conferences or meetings, nursing rounds, or purposeful rounding. So on page 544, it tells us purposeful rounding is a proactive, systematic, nurse-driven, evidence-based intervention that helps nurses anticipate and address the patient's needs. So an example of this is in long-term care facilities, they often have weekly wound rounds. And these wound rounds will include the treatment nurse or a nurse practitioner. It will also include the nurse manager as well as the dietitian, and sometimes therapy will be along with them. So they are collaborating about the wound care as well as the progression or deterioration of the wound. So on table 20-5, it compares behaviors and expected results. Okay, so everything that's listed on this particular slide is listed under behaviors, and then it tells you what the expected results are. So please take your time to read through them.